Welcome to this video on the imaging of Müllerian duct anomalies based on the ASRM classification system. We will be discussing optimizing protocols and diagnostic accuracy for these complex congenital defects. Müllerian duct anomalies, or MDAs, follow a clear embryological logic based on three main stages: ductal development, ductal fusion, and septal reabsorption. The clinical stakes are high, with MDAs having a prevalence of 13 to 25% among women with recurrent pregnancy loss. Our modality arsenal includes hysterosalpingography for initial infertility workup, 3D ultrasonography as a preferred initial non-ionizing method for younger patients, and magnetic resonance imaging, which is the gold standard for its multiplanar capability and soft tissue characterization. For an optimized MRI protocol, the workhorse sequence is 3D-FST2W, allowing for submillimeter volumetric acquisition. The golden rule is to align the coronal plane to the long axis of the uterus for accurate measurement of the external fundal cleft. The ASRM classification system categorizes MDAs into 7 classes, from hypoplasia/agenesis to drug-related anomalies. Remember the diagnostic rule of thumb: describe the anatomy first, as a detailed anatomic description supersedes a forced category fit. Class 1, agenesis or hypoplasia, is associated with Mayer-Rokitansky-Kuster-Hauser syndrome. Imaging hallmarks include an absent or hypoplastic uterus and a truncated vagina. Sagittal T2W imaging is crucial for surgical planning to measure the atretic vaginal segment length. Class 2, unicornuate uterus, results from asymmetric development. The primary task is to locate a rudimentary horn and check for functional endometrium. A non-communicating rudimentary horn with functional tissue carries a severe risk of rupture. Class 3, uterus didelphys, is a complete failure of Müllerian duct fusion. Imaging hallmarks include 2 widely divergent uterine horns and a deep external fundal cleft. The didelphys triad includes uterus didelphys, obstructed hemivagina, and ipsilateral renal agenesis. Class 4, bicornuate uterus, is a partial failure of fusion. The contour metric shows an external uterine fundus cleft greater than 1 centimeter. Cross-sectional imaging is mandatory to differentiate this from a septate uterus seen on standard HSG. Class 5, septate uterus, is the most common MDA. It is characterized by a normal external contour and a longitudinal septum dividing the internal cavity. Tissue characterization via MRI can differentiate between fibrous and muscular septa, impacting treatment approach. The subseptate uterus is a subtype of the septate uterus. Recurrent pregnancy loss and obstetric complications are linked to the poorly vascularized fibrous septum, which can lead to early miscarriage and increased risk of preterm labor. This diagram illustrates the morphological differences between a normal or arcuate uterus, a septate uterus, and a bicornuate uterus, based on the depth of the midline structure and the angle of the fundal indentation. Class 6, arcuate uterus, is a mild variant considered to be near complete reabsorption of the septum. Class 7, day drug-related, results from in utero exposure to diethylstilbestrol, presenting as a classic T-shaped uterine cavity and a high association with vaginal clear cell carcinoma. MDAs often have systemic associations, so always look outside the pelvis. Renal anomalies are common, affecting 30 to 50% of cases, and skeletal anomalies affect about 29%. Ovaries are typically normal, as they originate from the primitive yolk sac. This cheat sheet summarizes key findings, associated anomalies, and special considerations for each MDA class. Remember, the standard of care is to describe the exact anatomy before forcing a categorical classification. This slide provides an atlas view of different MDA types using ultrasound, highlighting bicornuate, septate, arcuate, and subseptate uteri. This visual comparison aids in understanding the morphological distinctions discussed in the ASRM classification.